Of localized renal mass. Good morning, respected examiners. I would like to present the case of Mrs. A, 65-year-old female, who presented with an incidentally discovered right renal mass. Good morning. Before you proceed, what do you mean by an incidental renal mass? Are most renal masses found this way? Sir, an incidental renal mass is one discovered unintentionally during an imaging study performed from an unrelated region. Indeed, with the increased use of cross-sectional imaging, the majority of renal masses are now detected incidentally. The classic triad of flank pain, hematuria, and palpable flank mass is seen in less than 10% of the patient and is often indicative of more advanced disease. May I continue with the history, sir? Yes, proceed. Mrs. A 65-year-old homemaker, has known history of hypertension for the past 10 years, managed with amlodipine. She has no history of smoking, no significant family history of malignancy, no history of hematuria, flank pain, or constitutional symptoms. An ultrasound of the abdomen for vague abdominal discomfort revealed a solid mass in the right kidney. What are the important risk factors for renal cell carcinoma that you would specifically ask about? Sir, besides the patient's age and hypertension, I would specifically about history of smoking, a significant risk factor. I would also ask about occupational exposure to substances like cadmium, asbestos, and trichloroethylene. A family history of renal cancer, particularly in a first degree relative, or a personal or family history of syndromes associated with renal cell cancer, such as von Hippel-Lindau disease, hereditary papillary renal carcinoma, or Burt Hogg-Dube syndrome, would also be crucial. You mentioned hypertension. According to Campbell Walsh, Urology 13th edition, what is proposed link between hypertension and renal cell carcinoma? Sir, as per Campbell, the association is complex. It is not definitively established whether hypertension itself is a direct cause or if the medication used to treat it play a role. Some theories suggest that chronic renal hypoxia and inflammation from hypertension may contribute to carcinogenesis. Another view is that hypertension might be an early manifestation of subclinical renal dysfunction caused by the tumor. You briefly mentioned the patient has no history of smoking. Why is a detailed social history so critical in a patient with a renal mass? Move beyond just smoking and alcohol. What specific occupational and environmental exposure are established risk factor for renal cell carcinoma? Sir, a detailed social history is critical because several environmental and occupational exposure are known to be carcinogenic to the kidney. While smoking is the most significant lifestyle risk factor, a thorough inquiry is also include occupational exposure. I would specifically ask about the patient entire work history, including jobs they held many years ago. Key exposures linked to RCC include cadmium. Cadmium is found in batteries, pigments, and metal plating industries. Trichloroethylene. Trichloroethylene is an industrial solvent used in metal degreasing. Asbestos. Asbestos is used in construction and insulation. Petroleum products. Petroleum is relevant for workers in gas station or refineries. Analgesic abuse. I would also inquire about any long-term heavy use of over-the-counter analgesic, particularly phenacetin containing compounds, which were historically linked to renal papillary necrosis and subsequent urothelial carcinoma, but have also have an association with RCC. Geographical location. Although less specific, some studies suggest a higher incidence of RCC in certain industrialized urban area, possibly due to environmental pollution. These factors are important not only for understanding the potential etiology in this specific patient but also for identifying at-risk population. The patient has no significant family history. How do you probe deeper into ensure you haven't missed a hereditary RCC syndrome? What specific patterns or associated conditions in family members would raise a red flag? Sir, to ensure I don't miss a hereditary syndrome, I would ask more targeted questions beyond just Does anyone have kidney cancer? My red flags would be multiple family members with RCC, especially on the same side of the family. Early age of onset. A family member diagnosed with RCC under the age of 45. Third one will be bilateral or multifocal tumor. A history of family member with tumor in both the kidneys or multiple tumor in one kidneys. Furthermore, I would ask about a specific condition associated with known hereditary RCC syndrome even if the family member wasn't diagnosed with kidney cancer itself. I would ask if any relative have a history of skin lesions such as fibrofolliculomas, which are pale skin papules on the face and neck for bird hog Dube syndrome. Neurological tumors, hemangioblastoma of the brain, spine, or retina, which are characteristics of von Hippel-Lindau disease. Benign uterine tumors, a history of uterine fibroids, leiomyomas, especially if they required early hysterectomy, as this is linked to hereditary leiomyomatosis and renal cell cancer. Collapsed lung or pneumothorax, spontaneous pneumothorax is a key feature of Birt-Hog-Tube syndrome. Finding any of these patterns would prompt a discussion about genetic counseling and testing, which would have significant implication for the patient and her family members. The patient denies constitutional symptoms, but RCC is known as the internist tumor due to its association with wide range of paraneoplastic syndrome. What specific non-neurological symptoms would you actively screen for in your review of systems, and what is their underlying pathology? Sir, certainly, because RCC can ectopically produce various hormones and cytokines, I would specifically screen for symptoms of the most common paraneoplastic syndrome, that is hypercalcemia. I would ask about constipation, fatigue, confusion, or bone pain. This is typically caused by the tumor's production of parathyroid hormone related peptide polycythemia or erythrocytosis. I would ask about headache, dizziness, or a ruddy complexion. This is due to the ectopic production of erythropoietin by the tumor. Anemia is actually more common overall, but polycythemia is a classical sign. Stauffer syndrome, which is non-metastatic hepatic dysfunction. I would ask about general malaise, anorexia, or weight loss. This syndrome present with elevated liver enzymes like alkaline phosphatase and coagulopathy, not from liver metastasis but from systemic inflammatory response caused by the cytokines like interleukin 6 produced by the tumor. Hypertension, although the patient is already hypertensive, new onset or difficult to control hypertension could be caused by the tumor producing renin. Identifying any of these syndrome is important as they can be marker of disease and their resolution after nephrectomy can serve as an indicator of successful treatment. You noted the patient is on amlodipine. How does a patient medication history influence your surgical planning and overall management, especially regarding nephrotoxicity and bleeding risk? Sir, a detailed medication history is crucial for perioperative planning. For this, I would focus on nephrotoxic agents. I would ask about any use of NSAIDs, example ibuprofen, diclofenac, which can cause acute kidney injury, especially in a kidney that will be under ischemic stress during surgery. If the patient is on ACE inhibitors or ARBs for hypertension, I will note that as they can also affect renal hemodynamics. Anticoagulants and antiplatelets is the most critical area before any surgery. I would specifically ask about aspirin, clopidogrel, warfarin, or any oral anticoagulants. The timing of stopping and potentially breathing these medication must be carefully planned with the prescribing physician to balance the risk of perioperative bleeding against the risk of thromboembolic event. Diuretics, medications like furosemide can affect the patient baseline fluid and electrolyte status, which needs to be optimized before surgery. I would also ask about over-the-counter supplements like fish oil, garlic, and ginkgo, as many can interfere with the platelet function and increases bleeding risk. Understanding the full medication list allows for a safe perioperative plan, ensures renal function is protected as much as possible, and minimizes the risk of bleeding complication during partial nephrectomy. Sir, on physical examination, the patient was comfortable with a blood pressure of 130 over 80 mmHg. There was no pallor or palpable lymphadenopathy. Abdominal examination was unremarkable with no palpable mass. Is it surprising not to find a palpable mass for a renal tumor? No, sir. Most localized renal tumors, especially those found incidentally, are not palpable. A palpable mass usually suggests a larger or more advanced renal tumor. You have taken the vitals, while most patients with incidentalomas have normal general examination. What specific findings in the general survey and vital signs could be clues to either locally advanced RCC or paraneoplastic syndrome? Sir, even with an incidentally found mass, a meticulous general examination is crucial. Specific findings that would raise my suspicion for more advanced disease or a paraneoplastic syndrome include cachexia or muscle wasting. This is non-specific sign of advanced malignancy and can be a poor prognostic indicator. Pallor, pallor suggests anemia, which is common with chronic disease or can result from intermittent hematuria. Facial flushing or plethora, this is sign of polycythemia, a classic paraneoplastic syndrome caused by ectopic erythropoietin production. Fever, unexplained fever, part of the classical triad, can be sign of systemic inflammation from the tumor or tumor necrosis. Hypertension, new onset or poorly controlled hypertension could indicate tumor production of renin. Tachycardia. Tachycardia may be present in patients with anemia, fever, or significant pain. Finding any of these would heighten the need to investigate for metastatic disease. You have mentioned the abdomen was unremarkable. Describe precisely how you would attempt to ballot a kidney. Why is this maneuver often negative even when a significant mass is present? Sir, to ballot the right kidney, I would have the patient lie supine and relax. I would place my left hand posteriorly in the right flank between the 12th rib and the iliac crest. My right hand would be placed anteriorly on the right upper quadrant just below the costal margin. The maneuver involves a firm upward thrust with the posterior left hand while the anterior right hand palpates deeply during the patient inspiration, which helps brings the kidney down. A ballotable kidney is felt as a distinct mass that floats up to strike the fingers of the anterior hand. This maneuver is often negative for several reasons. Retroperitoneal location. The kidneys are deep retroperitoneal organs, well protected by abdominal muscles and viscera, making them difficult to palpate unless significantly enlarged. Tumor size and location. Most incidentally discovered masses are small and not an intraparenchymal or exophytic and may not enlarge the kidney enough to be palpable. Obesity can make the ballotment nearly impossible. An upper pole tumor, like in this case, is situated high up under the diaphragm and rib cage, making it less accessible to palpation than a lower pole mass. Therefore, a non-palpable kidney does not rule out the presence of a tumor. In modern practice, a palpable renal mass is the exception rather than the rule. Beyond the abdomen, what specific physical finding would suggest local vascular invasion or metastatic disease? Sir, physical findings suggestive of vascular invasion or metastasis are critical for staging and prognosis. I would specifically look for sign of IVC thrombus, lower limb edema, bilateral pitting edema of the legs suggest obstruction of the IVC, dilated superficial abdominal veins. This indicates the formation of collateral circulation caput medusa to bypass the obstructed IVC. Signs of left renal vein thrombosis, acute left-sided varicocele. The left gonadal vein drains into the left renal vein. An acute non-reducible varicocele in an adult male can be a sentinel sign of left-sided RCC obstructing the venous flow. It is less common with right-sided tumors because the right gonadal vein drains directly into the IVC. Signs of metastatic disease, supraclavicular lymphadenopathy, a work a firm, non-tender supraclavicular node, Virchow node, can be a sign of lymphatic spread. Auscultation of the lungs, crackles or decreased breath sounds could suggest pulmonary metastasis or a pleural effusion. Bone pain, focal bone tenderness on palpation could indicate skeletal mets. The presence of any of these signs would immediately change the clinical stage and prompt further systemic imaging such as bone scan or dedicated chest CT. Is there any role for auscultation in the abdominal examination of a patient with renal mass? What might you hear and what would it signify? Yes, sir, auscultation does have a specific alibi limited role. I would use the bell of my stethoscope to listen over the renal angle posteriorly and just lateral to the umbilicus anteriorly. The primary finding I will be listening for is a renal artery bruit. A bruit in this location could signify a high vascular flow. A highly vascular tumor like clear cell RCC can create a turbulent blood flow audible as bruit. AV fistula. In rare cases, the tumor can erode into the renal vein, creating an AV fistula which generates a loud, continuous bruit. Renal artery stenosis. This is more common cause of renal bruit and will be a differential diagnosis, particularly in a patient with hypertension. While not common finding, hearing a bruit over a known renal mass would reinforce the suspicion of hypervascular RCC and is a finding worth noting. What specific laboratory investigation would you order for this patient as per the AUA guidelines? Sir, according to the AUA guidelines, I would order a comprehensive metabolic panel to assess renal function, creatinine and EGFR, and to check for hypercalcemia or liver dysfunction. A complete blood count to check for anemia or polycythemia, a urine analysis to look for hematuria. The patient lab results were within the normal limits with a serum creatinine of 0.9 mg per dl and EGFR of 65 ml per minute. What is the next imaging step and what information do you hope to gain? Sir, the next step is a high quality multi-phase contrast enhanced CT scan of the abdomen and pelvis. As per AUA guidelines, this is crucial for characterizing and staging the mask. I would look for tumor characteristics like size and location, its enhancement pattern, and for staging information such as local invasion, renal vein or IVC involvement, and lymphadenopathy. A triphasic CT scan revealed a 4.5 cm well circumscribed heterogeneously enhancing mass in the upper pool of the right kidney. The mass was exophytic. There was no evidence of perinephric fat standing, vascular thrombosis, or enlarged lymph node. Chest imaging was clear. With a 4.5 cm solid enhancing mass, what is the likelihood of malignancy and the most probable histology? Sir, for a solid enhancing renal mass of this size, the probability of malignancy is high, over 80%. The most common histological subtype of RCC is clear cell RCC, about 75%, followed by papillary and chromophobe RCC. Benign possibilities like oncocytomas are less likely. You ordered a multi-phase CT scan, which is the workhorse for renal mass characterization. In what specific clinical scenarios would you choose MRI over CT as the primary imaging modality for this patient? Sir, while multi-phase CT is the standard, MRI serves as a critical problem-solving tool and is preferred in several specific scenarios. Contrast allergy or contraindication. If the patient has severe allergy to iodinated contrast media, a contrast-enhanced MRI with gadolinium based agent is the preferred alternative. Impaired renal function. In patients with significant chronic disease, EGFR less than 30, gadolinium based contrast agent for MRI are often considered safer than iodinated contrast, although the risk of nephrogenic systemic fibrosis must be still considered with the older agents. Characterization of interdeterminate mass. MRI offers superior soft tissue contrast and is better for confirming angiomyolipoma. Chemical shift imaging in phase and opposed phase sequences on MRI can detect microscopic fat within the fat poor AML, which may appear as a solid enhancing mass. Differentiating cystic mass. MRI is excellent for evaluating complex cystic lesions, Bosniak 3 or 4, and can better distinguish solid components from proteinaceous or hemorrhagic debris. Assessing venous thrombus. MRI with MR venography is considered superior to CT for determining the presence and cranial extent of tumor thrombus within the renal vein or IVC. Young patients or those requiring serial imaging. To avoid cumulative radiation exposure, MRI is often preferred in younger patients, or those on active surveillance who will require multiple follow-up scans. On a contrast enhanced CT, what degree of enhancement is considered significant for a renal mass, and why is this threshold important? Describe the typical enhancement pattern of three most common RCC subtype. Sir, significant enhancement is defined as increase of 20 HU or more between the non-contrast and nephrogenic phase. This threshold is critical because it reliably distinguishes between solid vascularized tissue like RCC from benign cyst, which typically shows enhancement of less than 10 HU. Values between 10 to 20 HU are considered indeterminate and may require further evaluation with MRI or contrast enhanced ultrasound CEUS. The typical enhancement pattern for the main RCC subtypes are clear cell RCC. This is the most common and typically the most vascular subtype. It demonstrates avid heterogeneous enhancement in the corticomedullary phase, also known as arterial phase, followed by a rapid washout of contrast in the nephrogenic and delayed phases. This intense early enhancement is hallmark feature. Papillary RCC. This subtype is characteristically hypovascular. It shows mild, slow, and homogeneous enhancement. Compared to the surrounding renal parenchyma, it will enhance less and will not demonstrate the avid enhancement or washout seen in clear cell RCC. Chromophobe RCC. This subtype has more variable enhancement pattern, often described as moderate. It shows relatively homogeneous enhancement that is less intense than clear cell but greater than papillary RCC. A spoke wheel pattern of enhancement is sometimes described, but this is more classic for oncocytoma. Beyond standard CT and MRI, several advanced imaging techniques are emerging. Briefly describe the clinical utility of contrast enhanced ultrasound and dual energy CT in the workup of a renal mass. Yes, sir, certainly. These advanced techniques are valuable for problem solving in a specific situation. Contrast enhanced ultrasound is primarily used to characterize indeterminate renal lesions, especially in a patients who cannot receive iodinated or gadolinium based contrast. Its main application is to differentiate a complex cyst Bosniak 2F3 from a solid tumor. It uses microbubble contrast agents that are purely intravascular. It provides a real-time visualization of vascularity, a lesion that shows arterial enhancement that washes out is highly suspicious for malignancy, whereas a truly avascular lesion is confirmed as a simple cyst. It is excellent for resolving pseudo enhancement seen on CT. Dual energy CT. Dual energy CT helps in differentiating a materials based on their atomic number. Its main use in renal masses is to create a virtual non-contrast images from a single contrast enhanced scan. By scanning at two different energy levels simultaneously, DECT can differentiate iodine from calcification or high density material within a cyst. This is useful for accurately calculating true enhancement in a hyperdense cyst that is difficult to assess on conventional CT, thus avoiding the need for true non-contrast phase and reducing radiation dose. It can help characterize the composition of renal stone if found incidentally. For this 65-year-old patient with a 4.5 centimeter localized renal mass and no symptoms, what is the minimum required metastatic workup according to AUA EAU guidelines? When you would expect this workup to include a bone scan or a brain MRI? Sir, for this patient with CT1B tumor and no clinical sign or symptoms suggestive of metastasis, the EAU and AUA guidelines are in agreement. The minimum requirement staging workup is cross-sectional abdominal imaging. This has already been done with the multi-phase CT scan, which evaluates the primary tumor nodes and adrenal gland. Chest imaging. A chest CT scan is recommended for all patients with RCC as lungs are the most common site for metastasis. A chest X-ray is considered insufficient. I will explain this workup in the following situation. Bone scan. I would order a bone scan only if the patient has clinical symptoms like focal bone pain, elevated alkaline phosphatase level, or known metastatic disease elsewhere. Routine bone scan in asymptomatic patient with localized RCC are not recommended due to low yield. Brain MRI or CT. I would order a brain MRI or CT only if the patient has neurological symptoms such as new onset headaches, seizures, or focal neurological deficit. Routine brain imaging is not indicated for asymptomatic patients with localized disease. The exception would be in a patient with subtypes known for high risk of brain metastases, such as those with sarcomatoid features, although this would typically be determined post operatively. What is your clinical diagnosis and stage? Based on the findings, my diagnosis is localized right renal mass, highly suspicious for renal cell carcinoma. The clinical stage is T1B N0M0. The AUA guidelines mention renal mass biopsy. Would you consider it for this patient? Sir, according to 2021 AUA guidelines, a renal mass biopsy should be considered when the results are likely to influence the management, especially for candidates of active surveillance or ablative therapies. For a healthy 65-year-old with 4.5 cm solid mass who is a good surgical candidate, a biopsy may not be necessary if she opts for a definitive treatment like partial nephrectomy. I will discuss the pros and cons with her. You mentioned biopsy as an option. The classic teaching was to avoid biopsying renal masses due to the risk of needle tract seeding. What is the contemporary view on this risk, and what are the primary indications for renal mass biopsy according to the current AUA or EAU guideline? Sir, the historical concern for needle tract seeding has largely been mitigated with modern techniques. The use of coaxial sheath during core biopsy has made this complication extremely rare with incidence less than 0.01%. Therefore, it is no longer considered a major deterrent when a biopsy is clinically indicated. According to the latest AUA and EAU guidelines, the primary indication for renal mass biopsy are situations where the result will directly influence the management. First one is the active surveillance to confirm malignancy and establish the histological subtype and grade before enrolling a patient, particularly for small renal masses. Ablative therapy to obtain a definitive diagnosis before performing irreversible treatment like cryoablation or frequency ablation. Metastatic disease to confirm a renal primary in a patient presenting with metastatic disease before initiating a systemic therapy. To diagnose a suspected metastasis to the kidney from another known primary, example lung cancer, which would avoid unnecessary nephrectomy. Non-surgical candidate to establish a diagnosis in a patient who are unfit for surgery but may be candidate for systemic therapy or surveillance. Atypical masses to characterize masses with imaging features that are indeterminate for malignancy or to rule out infectious or inflammatory processes. You have decided to proceed with a biopsy. What constitutes an adequate sample and what is the reported diagnostic accuracy? What do you do if the report comes back as non-diagnostic? Sir, for an adequate sample, a core biopsy is strongly preferred over a fine needle aspiration because it preserves tissue architecture, which is crucial for subtyping. Guidelines recommend obtaining at least two good quality core with an 18 gauge or larger needle. The diagnostic accuracy of renal biopsy is high. The overall diagnostic yield is over 90%. When a diagnosis is rendered, the sensitivity for malignancy is approximately 90% and the specificity is 100%. If the biopsy is non-diagnostic, which occurs in about 10 to 15% of cases, my approach would be review the procedure. I would first discuss with the interventional radiologist to confirm the needle was accurately placed within the solid component of the tumor, avoiding the areas of central necrosis, which is common cause of non-diagnostic sample. Repeat the biopsy. If the initial attempt was suboptimal or if a tissue diagnosis remains critical for management, repeating the biopsy is the most appropriate next step. Proceed based on clinical context. If the mass was highly suspicious imaging feature in a fit surgical candidate, I will discuss proceeding directly to partial nephrectomy, counseling the patient that there is a small chance that the mass is benign. For a frail patient with a small mass, a period of close imaging surveillance would be an alternative. Let's change the scenario. The biopsy of the 4.5 centimeter mass shows an oncocytic neoplasm feature, suggestive of oncocytoma. What are the challenges with this diagnosis on a core biopsy, and how does it change your management plan? Sir, this result would strongly favor a benign process and significantly changes the management plan away from immediate surgery. However, there is a significant diagnostic challenge distinguishing benign oncocytoma from the eosinophilic variant of chromophobe RCC on a small core biopsy can be difficult as they share overlapping histological features. Given this, the management options are active surveillance. This becomes a preferred option. I would counsel the patient that the biopsy suggests a benign tumor and recommend monitoring with serial imaging, MRI or CT in 6 to 12 months to ensure stability. Partial nephrectomy. This may still be offered particularly for a younger fit patient or if the mass shows growth on surveillance. Excision provides a definitive diagnosis and is curative, but it carries a surgical risk that may be unnecessary for a benign tumor. Radical nephrectomy would be inappropriate. To help differentiate, immunohistochemical stains are crucial. Oncocytoma are classically positive for c-KIT, whereas chromophobe RCC is positive for both c-KIT and CK7. If pathology confirmed a P1, PT1B clear cell RCC, Furman grade 2 with negative margin, what is your follow-up protocol for as per AUA guidelines? For T1B low grade RCC with negative margin, the risk of recurrence is low. The AUA guideline recommend a risk stratified follow-up. This typically involves a baseline abdominal CT or MRI at 3 to 12 months post-operatively, then annually for 3 to 5 years. Periodic chest imaging and regular monitoring of renal function are also essential. Now assume the biopsy confirms clear cell RCC. The pathology reports provides a grade. Why was the ISUP WHO grading system replaced the older Fuhrman system, and what is the primary determinant of ISUP grade? Sir, the ISUP WHO grading system has replaced Fuhrman system because it offers better prognostic values and higher inter-observer reproducibility, which is particularly important when evaluating a small biopsy sample. The Fuhrman system assessed multiple nuclear features, leading to significant variability among pathologists. The key advantage of the ISUP system is its simplicity and objectivity. The grade is determined by a single feature, the prominence of nucleoli at 400x magnification. At grade 1, nucleoli are absent and basophilic, while at grade 2, nuclei are conspicuous and eosinophilic and can be seen at 100x magnification. At grade 3, nuclei are clearly visible and eosinophilic at 100x magnification. Grade 4, the tumor exhibits extreme nuclear pleomorphism and has sarcomatoid or rhabdoid features. This strict focus on nucleolar prominence becomes more reliable and reproducible prognostic marker. A higher SUP grade on biopsy is a stronger predictor of aggressive tumor behavior and is a key factor in deciding between active surveillance and immediate intervention for small renal masses. Assuming the patient wants definitive treatment, what are the management options for T1B N0 M0 renal mass? Sir, for 4.5 centimeter renal mass, the standard of care is nephron sparing surgery by partial nephrectomy whenever technically feasible. This can be done through an open laparoscopic or robotic assisted approach. Radical nephrectomy is reserved for cases where partial nephrectomy is not feasible. Thermal ablation is an option mainly for tumors under 3 centimeters. What are the main advantages of partial over radical nephrectomy for this patient? Sir, the primary advantage is preserving renal function, while oncological outcomes are equivalent for T1 tumors. Preserving nephrons lowers the long-term risk of CKD. This may reduce future cardiovascular events and improve overall function. For a 65-year-old, preserving renal function is critical. To summarize this, is a case of 65-year-old female with an incidentally discovered 4.5 centimeter localized right renal mass, clinical stage T1B N0M0, highly suspicious of RCC. My recommendation would be robotic assisted partial nephrectomy. You have classified this as a T1B mass. While active surveillance is a well established option for small renal masses, would you consider it for this 4.5 centimeter tumor? Justify your answer based on current guidelines. Sir, active surveillance would not be a primary recommendation for this patient. The AUA and EUU guidelines generally reserve active surveillance for T1 masses, those less than 4 centimeter, particularly in older patients or those with significant comorbidities that increases the surgical risk. My reasons for not favoring active surveillance in this case are tumor size at 4.5 centimeter. This T1B mass has a higher metastatic potential and a greater likelihood of being higher grade cancer compared to small T1 tumors. The risk of progression and metastasis during a surveillance period is significant. The patient is 65 years old and otherwise healthy. She has a reasonable life expectancy and is a good candidate for curative intent surgery, which offers excellent long term oncological control. While the growth rate on active surveillance is typically slow, around 1 to 3 per year, larger tumors can grow more unpredictably. Therefore, for healthy patients with T1B mass, definitive treatment is the standard of care to maximize the chance of cure. Active surveillance would only be considered if the patient had severe comorbidities that made her unfit for any intervention or if she unequivocally refused treatment after extensive counseling. You have recommended a partial nephrectomy if technically feasible. How do you objectively assess the technical feasibility and complexity of a partial nephrectomy for this 4.5 centimeter upper pole mass? What specific factors influence your decision to perform a partial versus radical nephrectomy? Sir, to objectively assess technical complexity, I would use a standardized nephrometry score such as the Renal score or the Padua score. These scoring systems evaluate key tumor characteristics on imaging. Renal score: R stand for radius, which is the size of the tumor. E stand for exophytic or endophytic mass. N refers to nearness to the collecting system or renal sinus. A stand for anterior or posterior polar line. L stand for location, the tumor's position relative to the polar lines. This patient tumor is described as 4.5 centimeter exophytic upper pool mass. This will likely result in low to moderate complexity score. The decision between partial nephrectomy and radical nephrectomy hinges on balancing oncological control with nephron preservation. I would favor partial nephrectomy because oncological equivalence. For T1 tumors, partial nephrectomy offers equivalent cancer-specific survival to radical nephrectomy. Renal function preservation. Partial nephrectomy preserves GFR, reducing the long-term risk of new-onset CKD and associated cardiovascular morbidity. Technical feasibility. A 4.5 centimeter exophytic upper pole mass is generally very amenable to partial nephrectomy. I would only convert to or plan for radical nephrectomy if intraoperatively the tumor was found to be invading the collecting system or hilar vessels to a degree that made safe partial resection with negative margin impossible. You suggest a robotic assisted partial nephrectomy. Compare this approach to open and pure laparoscopic partial nephrectomy. What is warm ischemia time and what is its significant in your surgical planning? Yes, sir, certainly. The choice of surgical approach depends on tumor complexity and surgeon expertise. Open partial nephrectomy remains the gold standard for highly complex tumors. It provides direct access, tactile feedback, and is excellent for rapid tumor cooling with iceless for prolonged cold ischemia. However, it involves a larger incision, more postoperative pain, and longer recovery. Laparoscopy partial nephrectomy. This is minimal invasive approach, has a steep learning curve, particularly for intracorporeal suturing. While it offers less pain and faster recovery than open surgery, it can be challenging for complex tumors. Robotic assisted partial nephrectomy. This is now the most common approach for T1 T2 masses in many centers. It combines the benefit of minimal invasive surgery with enhanced 3D vision, wristed instrument, and improved ergonomics. This facilitates precise disease dissection and rhinorrhaphy, often leading to shorter ischemia time and lower complication rates compared to pure laparoscopy. For this patient, robot assisted partial nephrectomy would be an excellent choice. Warm ischemia time is the duration for which the kidney's blood supply is clamped at body temperature during tumor excision and repair. Prolonged warm ischemia time is associated with irreversible nephron damage and poorer postoperative renal function. While there is no absolute threshold, the goal is to keep warm ischemia time under 25 to 30 minutes. Surgical planning for robot assisted partial nephrectomy involves optimizing steps to minimize this time, such as pre-placing the sutures and having an efficient surgical team. Some techniques like zero ischemia or selective clamping of segmental arteries can avoid global ischemia altogether for suitable tumors. Is there any role for neoadjuvant systemic therapy to downsize this 4.5 centimeter tumor before attempting a partial nephrectomy? Sir, at present, neoadjuvant therapy for resectable localized renal cell carcinoma is not the standard of care and should only be considered within the context of a clinical trial. However, it is an area of active investigation. The theoretical goal is to downstage or downsize the locally advanced or complex tumors to facilitate a less morbid surgery, specifically to convert a case from requiring a radical nephrectomy to being a feasible for partial nephrectomy. Recent trials are exploring the use of tyrosine kinase inhibitors like axitinib and immunotherapy combination, example nivolumab, ipilimumab, in the neoadjuvant setting. While some studies have shown tumor shrinkage, the response can be variable and there is risk of treatment related toxicity. This could delay the or prevent surgery. Therefore, for this patient relatively straightforward, I would proceed directly to surgery. The discussion of neoadjuvant therapy would be more relevant for a larger, more complex T2 or T3A tumor where nephron preservation is challenging.